Good afternoon. I'm Enrico Escher, Executive Director of the Frank J. Veith International Society, and very pleased for the opportunity to make few opening remarks. This society was created just 3 years ago by all previous vascular fellows trained under the guidance of Dr. Frank Veith. One of the principal objectives of this society is to honor the contributions made by Dr. Frank Veith over a long and productive career, recognizing his leadership role in moving our specialty into the endovascular arena. It is widely recognized that the endo revolution that took place in the late 90s was the most important step into successful transformation and survival of our specialty. We are pleased to have Frank with us today. Our young society will continue to bring to surface other important issues for our specialty and for our patients. Today's webinar is another step in this direction: how to promote minorities who are underrepresented in vascular surgery and improve the quality of care to the vascular patients. To create this exciting and timely webinar, we reached out to several national leaders in vascular surgery who will be introduced by our two great moderators. Our current president, Dr. Peter Klavitsky, is a professor emeritus at Mayo Clinic and editor-in-chief of the Journal of Vascular Surgery. Peter has been one of the most academically productive vascular surgeons with almost 500 scientific publications in referee journals. He also has served as president of the SVS and many other important societies. Thank you, Peter, for being with us today as well. Dr. Keith Caligaro is a professor of surgery at the University of UPenn and chief of vascular surgery at the very first hospital ever created in the United States, the Pennsylvania Hospital. Keith is currently the treasurer of the Society for Vascular Surgery. Dr. Caligaro has been actively involved in our previous webinars regarding women and Asian American promotion in vascular surgery as well. Thanks, Keith. Dear all, this society will continue to address important issues affecting all vascular surgeons, and it will always focus on the betterment of the vascular patients. With a quick reminder that our society membership does not require annual dues, I invite you all to join us. Thanks a lot. And Peter, please, could you start?
Thank you very much, Dr. Escher. Good morning, everyone. It is a real honor to serve as president of this distinguished society and follow the footsteps of giants like Mike Marin and Juan Parodi, who were previous president. And I thank Dr. Escher and the board of directors for the honor. Now, as we heard, the mission of this society is that of Dr. Veith's mission, which is to advance vascular surgery in the 21st century. And I think today's webinar fits exactly into this mission, and specifically focusing on young vascular surgeons' practice and education. How to promote minorities in vascular surgery. That's what we are going to talk about. And I will ask right away Dr. Keith Caligaro, who's a professor and the chief of section of vascular surgery and endovascular therapy at the Pennsylvania Hospital, to introduce our first speaker. Keith?
Yeah, thank you, Peter. It's an honor to moderate this with you. And again, I want to congratulate Enrico on this idea of having these continuing sessions dealing with these issues. So we'll get the ball rolling. And the first speaker, who I actually heard speak at the VAM back in August in San Diego, and it was a real pleasure to hear from her, is Elsie Ross from the Stanford University, and she will be discussing the good, the bad, and the ugly considerations by a young Black academic vascular surgeon. Dr. Ross.
Thank you to all the wonderful organizers for the opportunity to engage in this discussion today and talking about the good, the bad, and the ugly of being a young Black academic vascular surgeon. I have no financial disclosures. So my objectives today are to relay the considerations of at least one young Black academic vascular surgeon via some anecdotes, some data, and even though this is an international society, I apologize, but a lot of this, these anecdotes and data are from a US-centric perspective. So the good. To be perfectly honest, I had no interest whatsoever in becoming a surgeon when I started medical school. I had never met a surgeon or anyone who identified themselves as a surgeon growing up in a low-income neighborhood. So a lot of good things had to happen for me to have gone through training and become a faculty member in surgery. So as a third-year medical student, this is the division that I had access to here at Stanford. And some of you will look at this picture and say, wow, you're so lucky. Look at all these amazing people who've gone on to do amazing things. You must have been shepherded in to the specialty quite easily. But if anyone subscribes to the idea, Andy Bandura's idea and theory about social learning, it might not be a surprise to you that even though these people are quite great, because of the lack of similarity in many ways, I actually had a lot of doubts as to whether I could be successful in the way I define success in the field of vascular surgery. And it wasn't until I had the opportunity to scrub into a case with Dr. Wezo, where she expertly took care of a ruptured aneurysm using an open repair, then walked away from the table, and I noticed she was quite pregnant and in cowboy boots, that I think, aha, okay, maybe this specialty actually embraces diversity and differences. I lucked out even further because when I was a sub-I, Chelsea Dorsey had matched and was an intern here at Stanford. And so I was quite excited when I matched here as well, because I felt like I was joining a division that embraced diversity. Even so, on the national level, at least for the few times that I poked out of my little bubble of training, I didn't see a lot of national examples of minorities or even women who were leading the charge in vascular surgery. And this is borne out by research done by Karen Wu and others, where they looked at diversity and representation in vascular surgery around the time that I was starting my training. And diversity was lacking in general, and African Americans were the least represented in the SVS at the time. And when you looked at board membership, so like the highest level of representation in the SVS, it was crickets, just nothing. And so that can influence kind of how you think about your career long-term. It wasn't until my department chair sent me to my first Society of Black Academic Surgeons meeting that and it was my first year on faculty. And I finally discovered that Chelsea and I were not the only Black vascular surgeons in academia, and that there are actually a whole host of other people who shared similar interests, had many similar experiences, and we were all really passionate about improving representation, as well as trying to tackle issues of disparate outcomes in vascular surgery in very different ways. But at least it felt like there were a family of people that I can go to talk to about different ideas and to share the same struggles with. And so a lot of good, I believe today, is that there's no better time to be a Black vascular surgeon in training or academia, because there are so many examples of how you can be successful in the field. Furthermore, there's been a groundswell of support in diversity, equity, inclusion efforts from multiple stakeholders who are interested in tackling really hard problems of how we increase representation broadly. So the bad. So for anyone who spends any time in the DEI space, the idea of the leaky pipeline is quite familiar. And that is to say, despite the demographics in the United States, by the time you get to the pinnacle of the career that we all are currently practicing in, there's a huge drop off from 13% to nearly 20% Hispanic representation, Black and Hispanic representation in the US, to about half that in medical school. And again, half that as academic surgeons. There are issues that definitely need to be addressed at every stage of this process. In work led by Dr. Dorsey and others, while we found that there was an increase in representation of women in vascular surgery, when you do a deeper dive into minority representation, the trends are more paltry, and it hasn't been as significant in the vascular surgery integrated programs, and a little change in the vascular surgery fellowship. So there's a lot of work that still needs to be done to increase representation. So the ugly. I will say, quite frankly, that while I have seen a lot more representation of women and minorities in vascular surgery, both locally and nationally, I feel that the power that these individuals wield and their influence on the field has been a lot more subdued than I would expect. And when I think about reasons for why this may be, I believe that the opportunities that are given to individuals are distributed quite in an imbalanced way in our field and elsewhere. I think, and then when I think further about this, I think part of the problem is that we may be deluding ourselves into thinking that we live in a meritocracy, that the people that have made it really far and are super successful did it through their blood, sweat, and tears and all of their talent. And we forget about all the opportunities that have been bestowed onto someone that have led them to those positions. And so if you're a woman or a minority and you've been discriminated against and you believe in meritocracy, it can be a really frustrating experience that will cause you to potentially drop out of the system altogether. It's been borne out in previous studies that if you believe in the American dream, if you believe that if you work hard, you'll be successful and you'll benefit overall, and you're a marginalized group and you're working hard and things aren't working out for you, you get really frustrated and you either rage against the machine, drop out of the system altogether, or you develop very low self-esteem because you're not seeing the success that other people are having. And so translating this to being a young academic surgeon in general, we have struggles. We struggle to build a practice. We struggle to teach different learners effectively. We struggle to find good research ideas that can be funded, and also struggle to find leadership opportunities. And unfortunately, a lot of these struggles are amplified by our minority status. And to look at the literature a bit, minorities tend to have lower patient satisfaction scores compared to their white male counterparts. So think about that when you're trying to build a practice. Also, if you're a woman and you have a bad outcome, good luck in terms of your referrals, because these can drop significantly compared to men who have bad outcomes. Again, practice building becomes even more difficult. Minorities are less likely in general to receive NIH research funding, less likely to be promoted in academia, and less likely to benefit from mentorship and sponsorship. And to put a fine point on this, mentorship is the idea that someone helps you figure out how to get to a certain place in your career, whereas sponsorship is someone takes a chance on you and puts their reputation on the line to open the door for you. And I think this is needed much more. And I've benefited from this. And I think more minorities and women should benefit from this as well. So in conclusion, the field of vascular surgery is becoming more diverse, although when you look at the data, it's hard to say if whether this is intentional or just has been an accumulation of multiple generations of physicians. There are pipeline problems that abound and will always need to be attended to. Young minority surgeons are likely to struggle more than non-minority surgeons, and we should keep that in mind. And I think sponsorship and mentorship are necessary, and more can be done on this front to improve representation and success of minority vascular surgeons. Thank you.
Okay, well, thank you, Dr. Ross, for a very provocative and honest presentation. And the format of this symposium is that there will be a burning question asked by the discussant. And so Dr. Alabi from Emory University has a question for you. Dr. Alabi.
So thank you all for the pleasure of speaking and participating at this forum, and wonderful presentation and reflections, Dr. Ross, and always a pleasure to see you and hear you speak in such formative spaces as this. So this sounds fairly dismal. So for all the efforts by all the people in all the places, do you think overall that things are getting better for vascular surgeons who are underrepresented in medicine and surgery?
I think, the data tell a story that things might be getting better in terms of representation, but I don't want it to be just a numbers game. And we had a discussion about this, and I thought that you had some great insights and was wondering if you would share that.
Okay, well, I want to say optimistically, yes. When you see those numbers, it's difficult to say that specifically. And diversity, meaning a representative is present and accounted for by the numbers, is just scratching the surface, right? So retention has more to do with inclusion and equitable practices at all levels. When these discussions come up, everyone wants to say, well, I treat everyone equally and I'm not the problem. But what I would ask people to reflect on is, but are you part of the solution? If you want to know how to promote vascular surgeons who are underrepresented in vascular surgery, first, you need to hire them. How many Black or brown vascular surgeons have you trained? How many have you hired? How many have you sponsored for placement on editorial boards, regional society positions, SVS task forces or committees, invited talks, etc.? How many times have you asked a Black or brown vascular surgeon to give a talk on something that has nothing to do with their race? For example, and I'll just give you an example of something that I actually don't have any hard feelings about, but I have one of the highest volumes of iliac branch endoprosthesis in the state, but I've never been asked to give a talk on iliac artery preservation or management of complex aneurysmal disease. So I would say, reflect on these things, then we can talk and share about how you can share your power towards equitable transformation.
Thank you very much. Go ahead, Keith.
No, I was going to say, go ahead and introduce the next speaker. Thank you.
Well, I think I'm really hopeful we are going to find not only or discuss not only the problems, but also some of the solutions. And here it is. Bernadette Aulivola is going to talk to us about the top 10 suggestions to promote the recruitment, retention, and success of minority vascular surgeons who are underrepresented in medicine. Bernadette is a professor and director of the Division of Vascular and Endovascular Surgery and Therapy at Loyola University in Maywood, Illinois, and she has been a true champion of diversity, equity, and inclusion for our society. Bernadette?
Thank you. Thanks, Dr. Asher, Dr. Glowicki, for the invitation to speak today. So I'm happy to join you. If you gave me the opportunity, I have about 100 suggestions. So it was a little bit tough to narrow it down to 10, but we might as well get started with it. So I have no disclosures relevant to this talk. I'd like to just take a moment to highlight a really great online resource for diversity, and that's the APDS Diversity and Inclusion Toolkit. This is available online, and I'd really recommend anyone who hasn't taken a look at this resource and has questions about maximizing your support of DEI efforts and minorities underrepresented in medicine to just take a look at this toolkit. There are a slew of online resources, but this is one that I really value. So my first suggestion is really very simple, and that's just make a statement. So whether you're making a formal DEI support statement on behalf of your hospital system, your society, or your training program, or whether you're hashtagging Black Lives Matter on your Twitter page, simply making a clearly visible statement on your commitment to DEI issues and support of minority individuals in the field speaks volumes. Suggestion number 2, invest in the pipeline. Engage in outreach to underrepresented in medicine candidates early on. There are numerous US national student organizations that represent the interest of minority medical students. So if you represent a training program, for example, consider joining events like the annual SNMA residency fair. Find ways to connect with undergraduate or medical minority students and offer them opportunities like suturing or skills workshops, vascular surgery interest group meetings, shadowing opportunities. Fund a diversity sub-internship program and let them know about the plethora of student opportunities offered through our vascular societies, many of which are focused on offering opportunities to diverse students. Suggestion number 3 is showcase diversity. Demonstrate your commitment to diversity by highlighting the diverse members of your group. So publicly highlighting the accomplishments of minority surgeons in alignment with national heritage celebrations is just one approach. I was thinking about this because our own department just celebrated Hispanic Heritage Month with a department luncheon, and we highlighted a series of faculty and trainees distributed through social media and email, and that's just one example. Suggestion 4, promote representation in national societies. So I love that Elsie commented on her involvement in the Society for Black Academic Surgeons. One way that we can do that is to apply for institutional membership through our department, or to sponsor surgeon or trainee membership in national societies like those listed here that offer opportunity for peer groups, mentorship, academic opportunities, et cetera, that are focused on the minority members of our medical community. Suggestion 5 is we need to recognize the minority tax. So this has been defined as the burden of extra responsibilities that are placed on minority faculty in the name of efforts to achieve diversity. It's a bit more complex than that, but this can result in significant disparities when these efforts aren't recognized as being of value. So URM physicians are more likely to be asked to serve on a diversity committee or give a talk on diversity. We just talked about, not being invited to speak on your clinical area of expertise as a minority surgeon. URIM physicians are more likely to focus on clinical work for the underserved community, yet this can potentially result in lower revenues in some cases. So really, to counteract these effects, it's important not to rely solely on our minority vascular surgeons to do all of the work in the DEI realm, but to spread the work out, and yet to value that work equally to other academic contributions when it comes time to considering things like compensation or promotion. So, okay, suggestion number 6. Respond to bias and discrimination. So we all know that many institutions have set expectations for conduct and policies for responding to incidents of bias or discrimination. And we know that these events affect minority students, trainees, and physicians more frequently than others. But we as individuals have to have the personal responsibility of identifying and responding to those events real time. So we should aim to be strong allies to minority vascular surgeons by addressing bias incidents to the maximal extent. And that basically includes educating ourselves, interrupting the behavior, educating others, and reporting the event for formal consideration. So our goal should be on the, on that scale, the number 6. So, a true strong ally. Suggestion number 7 is to be a mentor. Mentorship is a fundamental aspect of the success of early career minority physicians. And sometimes this means thinking outside the box. So creative mentorship models have been described that make the best use of the small amount of minority faculty that we have. So one example has been described as a cascading model where groups of high school students are paired with several pre-med students who are paired with a trainee who are paired with a faculty member. And essentially, this amplifies the reach of a single faculty member in mentorship. But remember, we can't rely solely on our minority surgeons to mentor all minority students or trainees. There simply isn't enough time. And the concept of doing that would really amplify that idea of the minority tax. So importantly, it's been shown that a lack of racial concordance between mentor and mentee does not significantly impact satisfaction with the success of a mentorship program. So we all need to be in there providing mentorship. And it's important that we train our mentors to mentor effectively. Suggestion 8, it's been mentioned before in the last talk, be a sponsor. So while we can all serve as mentors, sponsorship really heavily relies on those who are already leaders in the field to make a public commitment to supporting the advancement of a talented minority surgeon or a student or a trainee. So sponsors can spotlight, they can open doors, they can enhance the visibility of a young minority surgeon. But as you all know, in our field of vascular surgery, given the current makeup, the weight of sponsorship rests predominantly on the shoulders of white male surgeons, leaders in the field. So we need to keep that in mind. Suggestion number 9 is intentionally recruit diverse applicants. So your recruitment technique, whether it's for your med school admissions committee or your training program or faculty position, should be aimed at enhancing the likelihood of appealing to a diverse group of applicants. So consider advertising the job through organizations that reach a wide group of underrepresented in medicine candidates. Support international medical graduate applicants. And once you identify applicants, consider them holistically. So we need to delve into their life experiences, personal attributes, commitment to the underserved, and leadership roles. Ultimately, all these efforts at recruitment for diversity depend on a program's ability to support, to retain, and to promote them. And finally, suggestion number 10, educate and train on diversity and inclusion. So this is not a one-time endeavor. Regular education and discussion about DEI related issues such as unconscious bias, microaggressions, mentorship, those are all critical to fostering an inclusive environment that's needed to support our diverse workforce. So again, I'd like to just thank you for the opportunity to speak, and I'm looking forward to whatever burning question you have in mind for me.
Thank you very much, Dr. Olivola. It was really a very insightful top 10, and I'm sure that you have got, as you said, several other suggestions. And we have a burning question, and that comes from no one else than Dr. Frank Veith, who does not really need an introduction. Dr. Veith, could you tell us your burning question?
Yeah, I'd first like to congratulate Bernadette and Elsie. I think they gave excellent talks. I'd like to congratulate Enrico for putting on this topic. I think it's extremely important, and I'm looking forward to the rest of it. I'll start out by making a bit of a comment, which will lead to a question. I think that this whole area is extremely important, but it exists in an imperfect world with man being part of it. And we know that man is an imperfect animal. And a lot of the things we're talking about really relate to one's biases. I can tell you, my first fellow was Black. My second fellow was Indian. My third fellow, Enrico Asher, I don't know whether he was Latin or South American, but he clearly was a minority. He certainly was a foreign medical graduate, as were several of my other fellows. So I feel that my bias was already way back in prehistoric times to give credence to the diversity principle. And I think my question gets to the bias business, because man is biased in everything he does. I feel that some of the points that were mentioned by our first two speakers, I feel that I was a minority. I had rejections of papers that were great. I had rejections of NIH grants, which were extremely good. They might have ultimately been funded, but the idea of rejection is one that we've all faced, because I guess we're all minorities. And I guess my question to Bernadette, and I thought your talk was excellent, how do you overcome these biases? Because just talking about them doesn't do it. The person has to do it intrinsically. And does that happen? And a sort of related question is, do you think we can overreact to this diversity problem and maybe give a disadvantaged conclusion to a, quote, non-diverse person because we give an unfair advantage to one of presumed diversity, be he Jewish, Black, foreign, whatever? Bernadette, how would you address that?
Yeah, I think while we are all maybe in some sense minorities, and we've all experienced discrimination, in no way will I ever experience the discrimination that my minority colleagues here on the panel have or will experience, or as a community. And I think, you know, the discussion about implicit bias really is, you know, sort of an opportunity for us to just look inside of ourselves and say, well, why am I making that decision? You know,
Right.
and I think we talked about that. We say, well, I'm not biased, right? But why am I making a decision when I hash out all the details of why I'm making it? There's something about some gut feeling or just something that I've seen so many times before. And so when you really hash out, I'll just, you know, say a basic example. If you're looking at 2 applicants for a fellowship position, you really just hash out, why are you ranking one above the other? You know, it's very important to figure out the question is, what are you valuing? So are you valuing a USMLE score that's 10 points higher more than, you know, the grit or experience of someone who was raised in an environment that they didn't have, you know, opportunities to flourish, to be able to achieve 10 higher points on their, you know, exam or something like that. So I think I appreciate your comments and concerns, but I think this is something that we need to constantly revisit as we look at decisions that we make every single day, in whether we offer a procedure to a patient, whether we rank someone higher or lower on a match list, you know.
So you're basically agreeing with me. You're saying that this recognition and elimination of bias is something all of us have to do as individuals. And your talks highlight that, the first 2 talks that we've heard. And I think that really illustrates the value of this particular webinar. I'm sure all of us that are on it would agree that we have to look inwardly to address our own biases and eliminate them from decision-making.
Yes, I agree.
Thank
Okay.
you very much. Keith, could you go ahead?
Yeah, we'll keep moving along. And Frank, I appreciate the comments your parrot has been making in the background there. They're very insightful. So the next speaker will be Dr. Manunga from University of Minnesota, and he'll be addressing critical elements required to building a successful clinical practice in vascular surgery. Jesse?
Maybe he's muted.
Yeah, you're muted, Jess.
Yeah, there he is. There you go.
Thank you. Thank you again, Dr. Usher and Frank Veith for the Society for the opportunity to present on critical elements required to building a successful practice in vascular surgery. I'm sorry. I have no conflict of interest as it relates to this talk. However, I'd like to disclose that the elements that I'm about to discuss today are by no means exhaustive. Instead, I have picked about 10 most important elements that I think are necessary to building a successful practice in vascular surgery. The first is humility. It turns out there are multiple reports in the literature that shows that clinician humility positively predict patient satisfaction, trust, as well as a number of other very, very important health-related metrics. The majority of these reports are published in the medicine literature. However, humility is equally important in a surgical practice, as so eloquently demonstrated here in this presidential address by Dr. Daniel Jack, where he said, ambition will open new frontiers in surgery and, as in sports, achieve new victories. Humility will help the surgeon to accept the necessary controls and checks and balances and ensure continuous quality improvement. The truth is, you might have come from the best training program in a known universe, but most people are just seeing you as starting out and you do not have results to show yet. A lot of the people don't care really where you've come from. in my experience, people really care about three things. Number one, who you are as a person. Number two, how you treat those people around you. And number three is your operative results. So humility will play a very, very important role in your success as a surgeon. The second thing is to be patient. And this is a very difficult task for most surgeons. However, in the words of Malcolm Gladwell, it takes 10,000 hours of intense practice to achieve mastery of complex skills and materials. And I believe that vascular surgery is a very complex field. Important to also remember that there's a learning curve associated with every procedure we practice. This has been very clearly shown in the literature, in cardiothoracic surgery literature, when talking about minimally invasive mitral valve replacement. The third thing is to find a mentor. And this, I believe, was the most important advice given to me when I was finishing fellowship. It's really, really important when coming out of training to join a group that prides itself in mentoring young faculty. Because the truth is, you will have some complications. And if you are associating your senior partners with you during those operations, they can actually go out and shield you from chatters in the hospital and in the operating room when bad things happen. It's equally important to remember the people who taught you the art. I'm about 9 years out of practice. Recently encountered a case of middle aortic syndrome, and I was debating whether to just do an aorto bypass or also bypass the renal arteries. And I made a call to Dr. Glovitsky, and he guided me, and the patient did very well. Number four is you have to take time, spend time with your patients and their family. It's important to get to know your family. You'll have a long-term relationship with your patients as vascular surgeon, and cultivating this relationship can be incredibly rewarding. There are reports that have showed that the quality of physician-patient's relationship is positively associated with the patient's overall functional health. So cultivating this relationship again is extremely important. Number five is to cultivate your source of relationship with your source of referral. A simple phone call I found out at the end of the operation to the referring physician. Dr. Smith, I finished an operation on Mr. Jones today, and the operation went very well. He'll be in the hospital overnight, and I anticipate that he'll be discharged home. That goes a long way. It's very important to also take the time, consider visiting your provider to introduce yourself, to let them associate a face with your name. As many institutions might have lunch and learn, or even grand rounds that can help you get in front of your medical colleague. All of these will help you grow your practice. The sixth thing is to be respectful. This is a good role in life overall. However, I found that when starting specifically, that OR staff can make or break a young surgeon's practice. It's important to listen to their suggestion. At the same time, remember that you are the leader, especially in the operating room, and trying to quote unquote be the best friend can at times be counterproductive. So try to strike that balance. The seventh thing is to embrace M&M. You will have complications, and some of them will be very horrific. Use M&M to learn, to find ways, sometimes from your peers, to avoid as best as you can the worst complications. At the same time, it's very important to also know your capabilities and limitations. Don't let bad complications paralyze you. Instead, use them to get better. The eighth thing is to share your outcomes by publications or presentation. Choosing to be active in research has several advantages, including keeping your medical knowledge up to date. It can also grow your practice and your reputation. The ninth thing is to be at the table. Certainly we are leaders in the operating room, but it's equally important to be leader in a hospital because a lot of decisions are being made at the leadership that impact our practice. We all know this saying that if you are not at the table, you will be on the menu. Important to use our voice and be agents for positive changes. Last but not least, it's important to protect our investment or reputation. It would do you no good to lash the nurses, but instead to go important to go on a balcony when things get tough, because they will get tough in the operating room. Remember that one foul word can ruin a well-tended reputation in a heartbeat. Know what's important to you. I recently read a very important article, a reflection, a survey of over 2,200 retired physicians, asking them what they would do differently if they were to go back in a practice. It wasn't surprising to see that majority of them said they would spend more time with their family or for personal wellness. So take care of yourself. Thank you again for the opportunity to present.
Well, that was a really terrific talk. And for a young vascular surgeon, you've provided a lot of useful insights. And I wish I had heard your talk about 20 years ago, to be honest. The person who will be addressing the burning question is Dr. Donna Mendez from Mount Sinai Medical Center. Donna, I haven't had a chance to see you in a couple of years because of the pandemic, but I'm looking forward to seeing you soon in New York. Dr. Mendez? I think she's here. Maybe she's not here. I thought she was. Okay. I thought she had been on the talk, but Enrico, you don't see her on the talk, right?
She's muted, right? I think she's muted.
Yeah, I thought I saw her, but
Yeah, I don't see her.
yeah, I don't see her anymore.
I don't see her. Maybe she had an emergency case or something. She's still a very busy clinician. She probably had an emergency. Okay, whoever wants to take a shot, or you, Keith, you can ask a question. Or anyone. Very good talk.
Yeah. Does anyone have a burning question for Dr. Mananga?
I have a comment. I think this is terrific, and it should be published in an article. It's particularly valuable to all young vascular surgeons going into practice. And there are many gems in that talk. Congratulations.
Thank you, sir.
Well, I have a question. I have a quick question, Jess.
Sure.
Again, terrific talk. And just like he said, I wish I had listened to this 40 years ago. I did all this mistake that you listed not to do. I still do them. Now I learned. But let me ask you, say that you made the mistake. You created a bad reputation in the hospital. Is this final to your life, or what? How you remediate it? What are the steps? Say that you came in thinking you're a big shot in the OR, and the poor nurse was trying to help, but you thought, oh, you're talking to a big surgeon, and you had a fight with her, or you demeaned her, whatever. So you made a mistake. You recognized it. Is this a final, or what steps should we take to remediate this situation?
This is a very good question. I think if you recognize that you've made a mistake, is the first thing is to look within yourself first and accept that you made a mistake and to be humble. And it becomes like a retail politics instead of a politics where you go, you give a speech and everybody believes in you. So then it becomes the job is harder, but not impossible. I think you start reaching one person at a time, talk to them directly, apologize to them directly, and then move on. And hopefully they'll have the courage to accept your apology. And if it's sincere enough, I think they will. The job is a little harder. It's like the say is true that it's hard to make a first impression the second time around, but it is possible, and it takes humility.
Excellent. Yeah, absolutely right. Thank you.
I had one question, if we have time, Dr. Calagaro.
Sure.
Jesse, I enjoyed your talk, and I was just curious, as I guess I have to consider myself as an older surgeon now. Each day feels like it, but do you see a difference in the surgeons of your era compared to the younger ones that you're training? Do you think these points that you brought up still apply to the younger surgeons, or do we need to emphasize different things to them as they start to go through the process of starting a career?
Right. We have on fellowship here. What I've found the difference between my own training and the where I'm at is that leadership, the tone is set by the leadership when you come into the program. When I came into the program, Dr. Glovitsky had stepped down as a chair or the chief of vascular surgery, and Dr. Bauer was the chief of vascular surgery. And he used to tell us, Jesse, if I set up the step here, I want you to jump here. And I think that tone is set up from the very beginning. I believe the program will produce the type of surgeons that they want to produce. So I understand that there are a lot of different elements, and the kids are becoming more entitled these days. But it's important for people with training to understand that they have 24 months for those who are coming in and to fellowship to learn how to take care of some of the sickest people in the operating in the hospital, and that requires investment. So you can learn things and work as hard as you possibly can. I think there's certain I can see the difference, yes, but the tone can be set at the level of the leadership to make sure that we're training very good surgeons for the future.
Okay, thanks, Jesse. I think we better move on to make sure we get through the talks. Peter, you want to take over?
Yes, it is a real pleasure to introduce the next speaker, Palma Shah. Palma is professor of surgery and program director of vascular surgery at the State University of New York in Syracuse, New York. And Palma is going to talk to us on controversies in the management of cardiovascular diseases in a diverse Hispanic population. Palma?
Thank you very much. Good afternoon. I'd like to thank Drs. Asher, Veith, Glovitsky, and Calagero for this opportunity. It's truly an honor and a pleasure to be with these esteemed people who I admire so much and from whom I continue to learn every single day. Thank you very much for that. So we know that Hispanics account for approximately 18% of the US population and is one of the fastest growing racial and ethnic groups. It's a heterogeneous population with socioeconomic conditions whose backgrounds are diverse, originating from Cuban, Mexican, Puerto Rican, South or Central American, and Spanish descent. They may be of any race, ancestry, ethnicity, or combination, and may come from any socioeconomic class linked by common language, Spanish. Therefore, it is truly difficult to consider the Hispanic population as a single group. This can make the prevention, diagnosis, and management of vascular disease difficult. We looked at cultural, racial, and social aspects of the Hispanic community in the United States, trying to assess their impact on vascular disease within this population. We also explored risk factors, medical and surgical treatments, and outcomes of vascular disease in the population, as well as the generational evolution of these conditions. And finally, we investigated the phenomena called the Hispanic paradox. This concept describes a suggestion of a lower cardiovascular mortality in Hispanics than in non-Hispanics, despite their clearly documented worse cardiovascular disease risk profile. Compared with non-Hispanic whites, Hispanics face higher risks of hypertension, obesity, diabetes mellitus, and ischemic stroke. Approximately 30% of adult Hispanics have diabetes mellitus. And on the contrary, the incidence of abdominal aortic aneurysms, peripheral arterial disease, and carotid stenosis in the Hispanic population appears to be significantly lower than in the non-Hispanic white population. Variation of major cardiovascular risk factors was evaluated in these two studies. Looking at Spanish-speaking regions and Latin American countries, widespread discrepancy for prevalence of cardiovascular risk factors in each ethnic group was identified. The MESA study demonstrated a lower prevalence of PAD in Hispanics compared with other ethnicities, reporting that Hispanic ethnic groups were significantly protected for PAD. The rates of lower extremity revascularization have been shown to be significantly lower in Hispanics compared to non-Hispanic whites. And Hispanics more often present with limb-threatening lower extremity ischemia and have higher rates of amputation, thus suggesting that Hispanics may be presenting with more advanced disease and worse outcomes. Generational evolution represents a gradual change over time in Hispanics living in the United States compared with those living in their native countries. It may be the result of a different eating pattern or food preferences in the children born in the United States compared with their parents who may maintain their established pattern of nutrition. If you look at table 1 on the left, US Mexican men, for example, had higher rates of hypertension, hyperlipidemia, diabetes mellitus, and obesity compared to men living in Mexico. Table 2 shows a comparison of Cubans living in America to those living in Cuba. The rates of obesity and diabetes mellitus were greater in the US living Cubans compared with native Cubans. Table 3 on the left shows comparisons of Puerto Ricans living in the United States to those in Puerto Rico. The rates of hyperlipidemia and smoking were greater for the US Puerto Ricans than for those living on the island. The prevalence of hypertension and diabetes was higher in those living in Puerto Rico than those living in the US. To the right, table 4 demonstrates the US South American Hispanic men who had significantly more hyperlipidemia, obesity, diabetes mellitus compared to men living in South America. In a large population-based cohort study, the risks of cardiovascular disease were significantly lower for Hispanics than for non-Hispanic whites with diabetes. Another population-based trial found that Hispanics had a greater burden of cardiovascular risk factors, and despite this, they were at lower risk of vascular death compared with non-Hispanic whites. We need to consider that the medical community may not be adequately prepared to address this because of limitations in understanding cultural and linguistic issues. Cultural competence has also been implicated in contributing to poor outcomes, medical errors, and difficulties with informed consent. We need to address the underrepresentation of Hispanic providers to those medical providers who've been deemed culturally and linguistically competent. Outcomes and rates of lower extremity revascularization, carotid endarterectomy, and abdominal aortic aneurysm repair in Hispanics were evaluated in this study compared to non-Hispanic whites. Hispanics had significantly fewer vascular procedures than whites and worse outcomes when they did. This included 3 times less carotid and aortic interventions. Hispanics were significantly more likely to present with symptomatic carotid disease and ruptured aneurysms. And in those patients with peripheral arterial disease, Hispanics had almost double the rate of diabetes, and more patients in this Hispanic group presented with lower extremity critical limb ischemia than claudication. As a result, Hispanic patients had significantly higher rates of major amputation after revascularization. Income and socioeconomic status also may negatively influence the outcomes of all patients, independent of race. This study looked at outcomes after vascular procedures, whereas both Black and Hispanic patients shared equally weighted frequency of major amputations. This was half as often in whites. The lower the socioeconomic level, the higher the risk of being treated in a hospital with less experience in lower extremity bypass. One can conclude from this study that Hispanics are less likely than non-Hispanic white patients to have a vascular intervention. However, when one was necessary, the patient presented at a more advanced or symptomatic stage of disease, resulting in worse outcomes. In conclusion, Hispanics compose a rapidly growing segment of the population with diverse backgrounds, ethnicity, socioeconomic stature from different geographies, and cultural differences that are affected by generational evolution and a cultural adaptation to life in the US. Understanding the cultural diversity in Hispanics is very important in terms of targeting preventive measures so we can modify cardiovascular risk factors which affect the development and outcome of the vascular diseases that we treat. Considering these aspects of the Hispanic differences will have an impact on future efforts to improve medical, endovascular, and open surgical outcomes of vascular treatments. Thank you very much.
Thank you very much, Palma. This is a kind of a sobering report pointing out the complexity of the medical care of the Hispanic population. And we are going to proceed now with a burning question from Gabriela Velasquez. Dr. Velasquez Ramirez is Associate Professor of Surgery and Director of the Vascular Surgery Fellowship Program of Wake Forest School of Medicine in Winston-Salem, North Carolina. Dr. Velasquez.
Thank you, Dr. Levitsky. Thank you so much for having me today in having this outstanding panel, and Dr. Shaw for her really succinct presentation. And Dr. Shaw, really your data is very telling. And as years pass by, as the Hispanic population grows in this country, we can really have more and more information about what are the disparities and really the bad outcomes that the Hispanic population can have given their lack of access to care. The socioeconomic and language disparities are so telling that really is one of the reasons why we are having such a gap in terms of the care that we can offer to them. And I really like the fact that you really emphasize the cultural education and the diversity within the treatment population. because this is what we really can make a difference. As we know, patients of Hispanic descent that live in the US have less ability to access our care. And as you mentioned, they come into the later stages of their disease and they have poorer outcomes. So what do you think are those actionable items that we as we try to be more diverse in our specialty, we could really care for these patients, and what we can do directly to improve their access to care and prevent them from having them come in such late phases?
Thank you, Gabriela. This is really an excellent question, and thank you so much for that. One challenge, I think, is really getting the patient to the doctor in a timely fashion. Patients may come from another country where the care was worse, and they're distrustful of physicians in general, regardless of where they are, so they're reluctant to go. Oftentimes, they're brought by their family members at a late stage of the medical problem. We also need to develop trust through education, including utilizing their family, as Dr. Munga had mentioned, engage the family in the conversation, make them comfortable so that they can entice their family member to be more engaged and trustful. I mean, they really have to understand why we are recommending the service and how this benefits them, which translates to language barriers. There have to be ways to include making sure that they actually fully understand what you're explaining to them. Oftentimes, the Spanish translator may be speaking a different dialect than this person is used to speaking. The people that work with me in my office state that the Cuban dialect differs from the Puerto Rican dialect that may differ from a South American dialect. So that needs to be considered. The patient may not fully understand that. Additionally, they stated that some words in one version of a Spanish-speaking country may have a different intonation or represent something different in another one. So that's the cultural competence that we have to understand. Furthermore, for lower socioeconomic cases, we have to develop ways to improve access to healthy food. We have to make sure that they can eat better from even a younger age, that the children are eating better, so we impact this later in life. Furthermore, they may have religious considerations that play a role, and the emotional stress of coming from a new life, from another country, not having their friends or family, or just a big change in their life may be impacting how your success in managing this patient. And again, I mentioned the cultural beliefs. For example, some of the Puerto Ricans believe that herbal medicine is your first line therapy, and the second line would be a pill. So that is something one can consider. And thank you very much for that.
Thank you very much, Palma. We are going to proceed with the next presentation. Keith?
Okay, so Dr. Vince Rowe is a professor of surgery at University of Southern California. And I had the privilege of hearing Dr. Rowe speak at the SVS board meeting in Chicago about 3 days ago. And he will address how to improve the vascular care of African-American patients, issues and solutions. Vince?
Thank you, Dr. Calagaro. I have no disclosures. So what are the issues? Well, it's quite interesting. This panel got together to discuss the issues mainly about the lack of minority involvement in clinical trials. And people that were involved in the think tank were patients that were 35 to 80 years old. Some were in clinical trials prior, some were not, referring physicians, as well as investigators. They got a lot of the cardiologists from the Association of Black Cardiologists to come and sit in, as well as trial coordinators. And they sat down and looked what were the issues. And these issues included the following: mistrust, lack of information, time and resource constraints, lack of awareness. But by far, the biggest one that the group identified was mistrust. And I think that's permeated through the Black community for quite some time, and in other communities, just like Dr. Velasquez and Dr. Shaw talked about. You wonder where it started. Well, there's been many things that have happened in the Black community. First one, one of the first ones here by the father of gynecology, had a statue erected, but performed numerous atrocities to enslave women as it came out. We know about Henrietta Lacks and her cell line that was replicated and profited on without her consent, as well as the Tuskegee experiment, which goes on in terms of atrocities and lack of treatment, proper treatment for these men that suffered from tertiary syphilis all the way till death. And I think you wonder, okay, well, that was historical, but that should be better now. But I'll just give you this example here during the current pandemic and what that mistrust that Black patients may have towards the medical community, what it did. You have a group that was higher risk for COVID and the complications of it due to hypertension and diabetes. These factors were probably still in place. Subsequently now enter in the coronavirus, and you're going to see increased deaths in the community as compared to other communities. Fortunately, the vaccine came along, but because of some of the mistrust and some of these same issues, a lot of people in the Black communities did not get vaccinated, which resulted in higher deaths. So I think it's still there. Hopefully it's going to get better, but let's see how we can work at it as physicians, as people in the healthcare field. One, I think, is become aware of our implicit biases. Dr. Veith talked about this earlier, and I think it's something that we have to do. We talked about it also last week at a conference at the UCLA course. And my comment was, you know, I can't make you go and check your cholesterol. I can't make you go to the gym and see how fast you can run on the treadmill. Same way, I can't make you go and look at your implicit biases. It's something that you have to want to do as a person, as a healthcare provider. But one of the keys is, this is what you have to remember, it's just a collection of attitudes and stereotypes. And oftentimes we don't even know how they got in our mind. One key is implicit bias is not prejudice, and not at all. In fact, they're very different. And implicit bias is usually unconscious, while prejudice is conscious. And prejudice is more of a learned response to a particular group of people, and also usually negative towards the people based on gender, religion, race, or what have you. This was one of the earlier studies where implicit bias was somewhat documented for us as physicians in healthcare. And it was a study where they used actors of different races and genders, and they read the same script of their cardiovascular complaints, the same one. They were all actors, none of them were patients. And then they looked to see who was referred to a specialist based on belief of their symptoms being related to their heart by a group of physicians, and those that weren't. And unfortunately, women and Blacks were referred less for cardiac catheterization, which in this scenario they did need, and especially Black women. They were by far the most not recognized in terms of their cardiovascular symptoms by the healthcare providers that were listening to these actors. And I think this is going to be important, because if we look at the projections, not only is diabetes going to continue to impact us as vascular surgeons, but it's going to continue to impact a group of people that are the most vulnerable and that need to really get the trust of the medical community, Black women and Black males. So this is going to continue to be a problem unless we as healthcare providers can get a handle on it. Dr. Velasquez and Dr. Shaw talked about cultural competency. And I had to learn this myself. I remember when I started my fellowship at the University of Tennessee, I was listening to two of the fellows, the vascular fellow who was the senior one and the critical care fellow, and they were both white. And we were in this talking, and then they started using these terms, talking about the color of other white people's necks or where they lived. And I said, well, are these terms okay to use? And why are you using? I had to find out. I wanted to understand what I was in now living in the South. I grew up in Los Angeles and two parents that were immigrants from the Caribbean. I didn't know any of this stuff, even though I heard about it on different TV programs, but now I was immersed in it and I needed to understand. And so I just asked them. They were my tutors for helping me understand some of the things of the culture there in the South in Knoxville, Tennessee. But don't be afraid to interact with these groups. Now, the groups for us, at least in Los Angeles, include Vietnamese, Armenian, Persian, and so forth. There are many groups that we have to try to understand, because I think it's going to be very important. The census predicts that now, 2019, 2020, for those under 16 years of age, the majority are going to be of the underrepresented groups. So they won't be considered underrepresented for long, as things are going to continue to change. And you really don't have to be Black. You don't have to be to understand Black patients. You don't have to be Hispanic to understand Hispanic and so forth. I think you just have to be culturally aware. This was a paper that kind of proves that. They talked to Black patients about the mistrust or trust they have towards the medical profession, and they identified issues that they felt were present. And the most important issues they talked about was just interpersonal competence. How did the person talk to them? Did they talk to them in a way that was respectful and show that they understood? Did they use terms and break things down to make it easier to understand? And they said it didn't matter if the physician was Black or whatever, it didn't matter as long as they talked to them in a way that they felt that they were valued and allowed them to understand the process. So you don't have to necessarily be of the same race to benefit people in other communities and build that trust that we need to as healthcare providers. And last, I think we do need to take action. Like I said, it's up to us to do it. Knowledge is power. We've always said that. And the more you know about not only your community, but also yourself, the better you'll be able to take care of your patients and also yourself and your families. If we continue just to keep our head down, I don't know if we're going to make a difference, and we're really going to have to, because we said the communities are changing and we're a much more diverse United States. Some people try to tell us that the United States is so fragmented, it's divided, there's this, there's that. Okay, that may be the case, and hopefully we can get together, but we in healthcare, where we have to take care of critical patients, I think we're going to need to really keep it together, because in the bottom line, in the end, the patients are going to be the ones to suffer. Thank you.
Okay, Vince, thank you very much. Again, very provocative and interesting talk. I don't know if Dr. Oderich was able to sign on. Apparently he had to travel and I do not see him.
Yeah, he's not here.
Yeah, right. So Vince, I guess you alluded to an issue now that we're all facing, which is, the issue with the pandemic and how, Black Americans, some are very resistant to the vaccine. And I guess, I got a lot out of your talk about what we can do as individuals, but what do you think? I don't know, how can you gain trust more globally for any group of patients? I mean, what can we do?
I think it's just a little bit at a time by the individual practitioners. I think that's where we have to make our change within ourselves, kind of like the whole look at the man or the woman in the mirror, Michael Jackson reference. But, it's when you speak of the pandemic, I saw it within my own home. I got vaccinated in January. My wife is Black and she's from England, and so I said, "Oh, when are you getting your vaccine?" She goes, "I'm not." I was like, "Well, what are you talking about?" And she goes, "I don't trust it." I was like, "Well, what do you mean you don't trust it?" And she just said, "I just don't trust it." And, I said, "Well, look, okay, I can't convince you because we'll just fight every night, but let's at least look at the data and I'll go through the charts and then it's your decision." So we took out, I think it was a New England Journal paper that talked about the rates of transmission and so forth. Here's the data. And then now you make your decision. And then we left it alone, and she didn't vaccinate until July. And, so the whole point is that this mistrust, you just don't know, it just is in there. And so it is kind of hard to break, but the only way I could think to break it with my wife was to just say, "Look, here's the data. Any questions? Do you understand everything? And, this is not a trick. This isn't, a chip or anything like that." And I think that approach is what we can use with our patients. And it's going to take the efforts of, I think, larger groups and societies and people to put information out there that people can finally believe to make an impact.
I've experienced a little of the same thing. I have a niece who refuses to get the vaccine, and anyway, it affects all of us. So anyway, Enrico, do you want to open this up to everybody? Or
Yeah, absolutely. You guys are moderating, is fine. I just have a question, just a comment also regarding Dr. Rowe's presentation, which was excellent, by the way, and is very realistic and provocative. I believe I have a very large African-American population. I always had when I was in the Bronx, then I went to move to Brooklyn. I did hire minority physicians. All my previous partners were minority. But I have to tell you, I think the one thing that I learned on my own experience to break into that trust thing, to try to break that trust, is how you introduce yourself to your patients. When I come in and when I open the door and I greet them, giving the impression, which actually not impression, but that I'm welcoming them there. And I sit down in the chair and I start talking to them, or talk a little bit about the family, or if they come with the son, I talk to the son as well. That sometimes breaks all this mistrust that has been built for all these years. I think it's very important. And somebody mentioned humility. I think that's probably the thing Jesse mentioned, the humility, which is very, very important. I think you're humble, you sit up there and you talk on a personal basis. I think a lot of this mistrust goes away. And, some of the best rewards I have during my professional life has been actually with Spanish and African-American patients. They're very, very thankful. And I think it's because I always did not want to have that difference. Frank said he doesn't know where I come from. I don't know where I come from myself. So we're never going to solve this problem. But the fact is, breaking that mistrust is how you introduce yourself, how you talk to the patient. And the first impression is very, very important. That's my comment. What do you think, Vincent?
I agree with you completely. I mean, for me, it's more the Spanish community here, and I had to learn and understand, it's not Spanish community. It's okay. These people are from Salvador. These people are from Honduras. These people are from Mexico. These people are from Spain, Colombia. Everything is different, and you have to understand that and recognize that and treat people accordingly. Someone from El Salvador doesn't want you to say, yo, you're like Guatemalans. It's a different country, and respect that. And so I've had to learn that with the patients I take care of. And you're right, it's how you introduce yourself and how you respect their culture.
Right. Thank you.
I have a question to practically everyone in the panel, and it is about unconscious bias. Vince really spoke very well about this issue, that we should look into ourselves and try to, find out if we have an implicit bias or not. But I don't think that is enough. There must be some way to educate us or our practice or our partners. So I am wondering what you think is the best solution to learn our implicit biases.
Well, I think, it starts with, for me, I actually didn't think I had any. I was like, okay, I grew up here. I'm pretty open. I think I consider myself very non-judgmental, and I didn't think I had any. And then I took that examination that we had to take on the vascular surgery board, and mine were exposed. And I was pretty shocked. If my dad was alive, he would have shot me in the head or something. And he was, what's wrong with you? Because my implicit bias was that I felt that white men were the smartest. And I was using, and my bias was that they were smarter than women and other Black people. And that's what came out on the test. And I had to whoa, where did I get this from? And why do I have this? And what have I done to my other Black colleagues, Hispanic colleagues, women colleagues? What have I been doing all these years? And I thought I was equitable to everyone. And I had to kind of sit back and look at it. I'm afraid to take the test again because I think it's not true, but it came out being true. So it starts, looking in, and I had to deal with it. And I still don't really have an answer for it, but at least I looked, and I'm thinking about it, and I'm making sure that I'm as fair as I feel I am to everyone.
Enrico, there's only a minute left. I'm
Yeah,
sorry to
I
say.
think,
Can I make one quick comment?
30 seconds, Frank.
Yeah, I think one of the things we can do to instill confidence in our patients, you may not agree with this, is give them our cell phone number. I know I have great trouble when I or my wife try to reach a doctor's office and all we get is a voice recording and we can't reach them. And if you give the patient your cell phone number and say, look, if you have trouble, it's really a problem, you can't contact me or through my office, here's my cell phone number. I just like everybody's comment on that.
Yeah, I can just add that Jim Stanley once told me that he was never sued all these years because what he does, he gives his phone number to the patient. I told him, Jim, I'd rather get sued. Because these patients, the problem with the calling is that the majority will be very nice, but some of them, they'll call you every 5 minutes for every issue that's not vascular related. But you're right, Frank, unless you have a very selected practice, I think, in my opinion, it is hard to do this, to give the phone to everybody. But I would like to listen to everybody. It's a great question, actually. Great comment.
I think I just have one comment, and that comes to the humility that Jesse mentioned. To me, it's communication, communication before, set the goals, set the expectations, have your connection with the family. Nothing beats communication.
Absolutely.
Any of the speakers want to comment?
Cell phone is a great way to do that, Peter.
Well, Dr. Alabi mentioned, just the last comment now, Dr. Alabi mentioned that she has a tremendous experience with the iliac branching. And I'm at fault, Dr. Alabi, because I put recently a webinar co-sponsored by Gore exactly on this issue. And I actually had asked them, the company, because I couldn't find, because I did not do a very good literature search. I could not find, I want a woman representative in this webinar, 1 or 2 or 3. And I looked very cursory and I couldn't really identify anything. So I came up with the idea, and I spoke to the previous president of the SVS, that maybe people that are interested in participating in educational activities, they should have a place to communicate or to mention or to put their names in and say, listen, I am interested in this. I have that kind of experience. So it'd be much easier for somebody like me who's organizing webinars to go and find it, because it's not easy sometimes to find. You may have done a lot of work, but it may not come out right away. So that point that you brought up was very important, and I think it's good. All right, so unfortunately, it has been a fantastic webinar. It's very exciting. I wish all of you contribute with your 600-word essay regarding your presentations. The moderators can also make some comments, and we'll get it published, because I think this webinar one of the best we've had. A lot of pearls. I took a lot of notes, which I'm going to share with the residents tomorrow and the attendings and the fellows. And I want to thank you all for really a fantastic webinar. And particularly, I want to thank Dr. Veith, who has been inspirational to create that society. And as you see, he always have a great comment, including the one on the phone. Thank you very much all, and have a great afternoon. Bye-bye.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you.
Bye-bye.